I want you to imagine just for a second the sheer scale of this really hidden medical intervention that's happening all around the globe right now.
Right. It's massive.
It is. I mean, every single morning, millions of people wake up and swallow what is essentially a microscopic chemical master key.
Or, they apply a patch or rely on a localized implant.
Exactly. They introduce this synthetically engineered molecule right into their bloodstream. And that molecule proceeds to completely, hijack one of the most ancient, tightly regulated, and just powerful endocrine pathways in human evolution.
Yeah, and we treat it like it's no big deal at all.
Right. It's just a daily chore, little plastic dial sitting next to the toothbrush. But the reality is taking hormonal contraception is kind of the biological equivalent of walking into the control room of a nuclear power plant, just casually flipping a dozen massive switches and trusting that the system won't melt down.
That is a very apt way to put it. The contrast between that mundane packaging and the really profound physiological impact is staggering.
Seriously. Whether you take these medications yourself, or maybe you're the clinician trying to prescribe the right one, or you just, interact with people who rely on them, which is virtually everyone, this invisible chemical manipulation is dictating physiological states all around us.
It really is. I mean, we hand a patient a little plastic compact with the days of the week printed on it, but what we're actually dispensing is, well, a tool for profound endocrinological suppression.
Yeah, suppression on a massive scale.
Right. When you peel back the layers and examine the molecular why behind these medications, the perspective just shifts entirely. You stop seeing a simple consumer product and start seeing a masterpiece of biological hacking.
A biological hack. I love that. And deciphering that biological hack is, well, that's our entire mission today. Okay, let's unpack this. We are pulling back the curtain on a set of notes and clinical transcripts from Helix Talk.
Which is an excellent educational guide compiled by pharmacy faculty, by the way.
It really is. Their goal, in ours today, is to decode what they term hormonal harmony. We're going to map out the baseline biological machinery of the ovulation cycle, navigate the incredibly complex pharmacology of synthetic hormones, and most importantly, explore how clinicians troubleshoot the system when this synthetic harmony fractures and side effects take over.
Because before we can even begin to understand how to freeze or manipulate the system, we really have to look at the baseline mechanics. We have to map out the HPG axis.
Right, the hypothalamic pituitary gonadal axis. It's a mouthful, but it's the engine driving this entire conversation.
Exactly. And a lot of the foundational literature and, frankly, a lot of patient education throws around the number 28 days as if the menstrual cycle is this perfectly calibrated Swiss watch.
Oh, yeah, the legendary 28-day cycle.
Right. But it's vital to throw that number out the window immediately. 28 days is just a statistical average.
Oh, really? So what's actually normal?
A perfectly healthy, physiologically normal cycle can span anywhere from 21 to 40 days.
Wow, 21 to 40 days, that is a huge window.
It is. The duration is highly variable, but the underlying machinery, the communication network, is rigidly constant. It relies on this continuous multi-tiered feedback loop.
Right, between the hypothalamus deep in the brain, the anterior pituitary gland sitting just below it, and the ovaries. It's like a chemical relay race.
That's a great analogy. The hypothalamus acts as the primary pacemaker, essentially.
And it releases gonadotropin-releasing hormone, right,
Yeah.
GnRH. But what always strikes me about GnRH isn't just that it's released, it's how it's released.
Yes, the how is critical here.
It's not just a steady stream, right? It's pulsatile. It pulses out in these highly specific rhythmic bursts, travels down the portal blood system to the anterior pituitary, and commands that gland to synthesize our two primary actors.
Luteinizing hormone, LH, and follicle-stimulating hormone, FSH.
Exactly. And why is that pulse so important?
Well, what's fascinating here is that the pulsatile nature of GnRH is the linchpin of the whole system. If the hypothalamus just, dumped a continuous stream of GnRH, the pituitary receptors would actually downregulate.
Wait, they would just shut off.
Exactly. They'd become desensitized and shut off entirely. The rhythm is what keeps the system alive.
Oh, wow.
Yeah. So once the pituitary receives that rhythmic signal, it pushes FSH and LH into the systemic circulation. And their main targets are located down in the ovaries.
Which kicks off the first major phase of the cycle, right? The follicular phase. And chronologically, day one of the follicular phase aligns precisely with day one of menstruation.
Which I know feels somewhat counterintuitive when you first look at it.
It totally does. The physical shedding of the uterine lining from the previous cycle is like simultaneously day one of the construction phase for the next cycle.
Exactly. As the shedding occurs, the pituitary is already pumping out FSH, and FSH does exactly what its name implies. It stimulates a cohort of follicles in the ovaries to wake up and start developing.
So we've got this cohort. It's a group of maybe a dozen or more follicles, and each one contains an immature egg, an oocyte. They all begin to grow because of that rising FSH.
Right. But human biology is generally designed for single pregnancies, not litters. So this cohort enters into what is essentially a brutally competitive biological elimination round.
I always compare this to a biological reality TV show. You have this bunch of follicles, they're all competing, but only one can win the dominant spot.
That is a surprisingly accurate way to frame it. As these follicles grow, they start producing their own hormone, estradiol.
And this is where the cellular mechanics get incredibly cutthroat, right? They're all desperately trying to grow, drinking up the FSH and pumping out estradiol. But eventually, one follicle just outpaces the rest.
It becomes the dominant follicle, and once it secures that top spot, it essentially weaponizes its own estradiol production.
Weaponizes it. How?
It pumps out so much estradiol that it sends a massive negative feedback signal back up to the brain. It tells the pituitary to drastically cut back on FSH production.
So it aggressively shuts down the competition.
Precisely. By driving down the systemic levels of FSH, the dominant follicle ensures that the smaller, competing follicles, which, remember, require high levels of FSH to survive, undergo atresia.
They basically just wither and die off.
Yes. The dominant follicle survives because it has developed a massive density of FSH receptors. It can thrive on the lower, depleted levels of FSH that it just caused. It has secured a total monopoly on the cycle.
That is wild. So this dominant monopolistic follicle is now growing massive, and it's churning out exponential amounts of estradiol.
And that estradiol is doing the architectural work of rebuilding the endometrial lining in the uterus, which halts the menstrual bleeding.
But it's also doing something bizarre at the level of the brain, right?
Right.
Usually biological systems rely on negative feedback. Like too much of hormone X shuts down the factory for hormone X.
Right. That's the standard operating procedure.
But as we approach the midpoint of the cycle, roughly day 14 if we're using averages, that massive sustained spike in estradiol actually triggers the exact opposite response from the pituitary. How does that negative feedback suddenly flip to positive feedback?
It is one of the most fascinating receptor-level phenomena in human physiology. For the entire first half of the cycle, estradiol acts as a brake on the pituitary.
Okay, a break.
But when that dominant follicle produces an incredibly high, sustained concentration of estradiol for roughly 48 hours, it fundamentally alters the sensitivity of the gonadotropic cells in the anterior pituitary.
So it, like, primes them.
Exactly, it primes them. And instead of suppressing LH, that critical threshold of estradiol triggers those prime cells to simultaneously dump all of their stored luteinizing hormone into the bloodstream.
Ooh, and this is the famous LH surge.
That's the one.
And that surge is basically the biochemical hammer that cracks the follicle open. The massive spike in LH causes the dominant follicle to literally rupture, releasing the mature egg into the fallopian tube. Ovulation is achieved.
The egg is released and it begins its journey. But the remnants of that ruptured follicle left behind in the ovary, they don't just disintegrate.
No. What happens to them?
They undergo a rapid, dramatic cellular transformation to become an entirely new temporary endocrine gland called the corpus luteum.
A brand new gland just forms.
Yep. And this marks the transition into the third act, the luteal phase.
Okay, so the corpus luteum takes over the factory, and its primary manufacturing output shifts away from just estradiol and heavily toward progesterone.
Right, progestation. It is a hormone solely dedicated to preparing and stabilizing the environment for potential pregnancy.
Got it. So progesterone travels to the uterus and transforms that proliferating endometrial lining into like a highly vascularized secretory lining.
Essentially creating a nutrient-rich sponge ready to catch and implant a fertilized embryo.
But progesterone has a second, equally critical function, right? It acts as the ultimate systemic brake pedal.
It does. It travels back up to the hypothalamus and the pituitary and completely halts the pulsatile release of GnRH, crushing the levels of FSH and LH.
So it basically screams at the brain, stop the assembly line, we might have an embryo, do not wake up any new follicles.
It locks the system down completely. No new competition. Now, if an embryo does implant, it produces its own hormones to keep that corpus luteum alive and pumping out progesterone.
But what if there is no fertilization?
If there's no fertilization, the corpus luteum has a strict biologically programmed lifespan of about 10 to 14 days. Once it hits that expiration date, it simply degrades.
It degrades into scar tissue, right? A structure called the corpus albicans.
Exactly. And as the corpus luteum dies, the massive amounts of progesterone and estradiol it was producing suddenly vanish from the bloodstream.
Just a sudden drop-off.
A total withdrawal, and that sudden withdrawal of hormonal support causes the highly vascularized uterine lining to destabilize and slough off, triggering menstruation.
And at the same time, the disappearance of progesterone removes the brake from the hypothalamus. So GnRH begins to pulse again, FSH begins to rise, and a new cohort of follicles wakes up.
The cycle resets entirely.
Wow. Okay, so holding that incredibly complex, tightly orchestrated cascade in our minds, the rising estradiol, the LH surge, the progesterone brake, how do we manipulate it? I mean, if this system requires such precise chemical thresholds, how exactly do hormonal contraceptives trick it without breaking it?
Well, what's fascinating here is that the brilliance of the pharmacological intervention is that we aren't introducing chaos, we are introducing an artificial stasis.
Okay, an artificial stasis.
We are exploiting the system's own negative feedback loops. When a patient takes a combined oral contraceptive, which contains synthetic estrogen and a synthetic progestin, they are artificially introducing a constant, steady stream of those hormones into the blood.
So we are essentially locking the body into a permanent simulated luteal phase.
Precisely. By maintaining an artificially high level of synthetic progestin, we are tricking the hypothalamus into believing that ovulation has already occurred and a corpus luteum is currently active.
Ah, so the brain thinks the job is already done.
Exactly. The progestin clamps down on the GnRH pulses. It suppresses the FSH, meaning no new follicles are ever recruited or grown.
Okay, that makes sense for the progestin. But what about the synthetic estrogen? If the progestin is what shuts down the follicle growth, why do we even need the estrogen component? Why not just give everyone progestin and call it a day?
That is a crucial mechanistic question. Estrogen serves two major purposes in these formulations. First, it acts synergistically with the progestin to heavily suppress that LH surge.
Right, and if there is no LH surge, there is absolutely no ovulation.
Exactly. Second, and practically more important for the patient's daily life, the synthetic estrogen provides stability to the endometrial lining.
Stability, like structural support.
Yes. Without that estrogen component, the lining would become incredibly friable and unstable, leading to constant, unpredictable daily bleeding. The estrogen is there to manage the bleeding profile just as much as it is there to prevent pregnancy.
Oh, wow. It's an incredibly elegant biological illusion. We are feeding the brain the exact chemical signature it expects to see after ovulation, permanently blocking the trigger that causes ovulation.
It's beautifully designed.
But, as flawless as that sounds on a molecular level, the source material pivots hard into the reality of how these methods actually perform in human populations.
Right, moving from theory to practice.
Exactly. We have to talk about the efficacy spectrum, which is measured in failure rates, meaning the number of pregnancies per 100 women over a year of use. And looking at the non-hormonal data, it paints a pretty stark picture of why we resorted to hacking the endocrine system in the first place.
The non-hormonal data really illuminates the sheer biological drive of human fertility. If you look at methods like calendar tracking, basal body temperature monitoring, or tracking cervical mucus, the failure rate hovers around an astonishing 25%.
Wait, 25%. So 1 in 4 people using these methods will experience a pregnancy within a year.
1 in 4, yes.
Which honestly makes sense when you understand the mechanics. Sperm can survive in the female reproductive tract for up to 5 days.
Exactly. They are very resilient.
And as we just discussed, that 28-day cycle, that perfect day 14 ovulation, is a myth. The LH surge can shift based on stress, illness, or just natural variation. So trying to calculate a moving target with a 5-day margin of error is a statistical nightmare.
It really is. Even barrier methods, which physically block the sperm, have surprisingly high failure rates in the real world. Condoms and diaphragms sit at about a 20 to 22% failure rate.
That's still really high.
And spermicides, which rely on chemical disruption of the sperm membrane, fail at a rate of 27 to 28%. But this brings up the most critical statistical distinction in all of contraceptive medicine.
The gap between perfect use and typical use.
Yes, the massive chasm between perfect use and common use effectiveness. Perfect use assumes laboratory conditions.
Right, like the condom is applied flawlessly every single time, exactly on time, without a single tear or slippage.
Which isn't reality. Typical use is the real world. Typical use accounts for human exhaustion, miscalculation, slipping, breaking, or just simply forgetting in the heat of the moment.
And human error is the ultimate variable. But, and here's where I have to pause, the source notes. There is one glaring exception in the non-hormonal category that completely sidesteps human error: the copper IUD.
Yes, the copper IUD is fascinating.
The notes say its efficacy rivals permanent surgical sterilization, sitting at well over 99% effectiveness. But it uses zero hormones. It doesn't hijack the pituitary. It doesn't trick the hypothalamus. It doesn't stop ovulation. How does a tiny piece of plastic wrapped in copper wire achieve that?
It's all about the localized environment. It creates a localized, highly toxic environment for sperm. The copper wire constantly releases free copper ions into the uterine cavity.
And what do those ions do?
These ions trigger a massive localized inflammatory response. They recruit macrophages and white blood cells into the uterus.
So it's basically creating an immune battlefield.
Exactly. Furthermore, the copper ions themselves cause severe oxidative stress. They induce lipid peroxidation in the cell membranes of the sperm, essentially shredding the sperm's motility and viability before they can ever reach the fallopian tubes.
Wow.
It acts as a highly effective, continuous spermicidal wasteland.
A spermicidal wasteland.
Oh.
So it's incredibly effective and totally bypasses the systemic hormonal side effects. If I'm a patient, this sounds like the holy grail. Why wouldn't everyone just use the copper IUD if it's practically surgical in its effectiveness without hormones?
Because that localized inflammatory response I just described doesn't just affect the sperm, it affects the endometrial lining too.
Ah, collateral damage.
Exactly. The cascade of inflammatory cytokines and prostaglandins often leads to significantly heavier, longer menstrual bleeding and dramatically intensified cramping.
Right, because there are no synthetic hormones involved, there is zero cycle regulation.
The patient still experiences all the natural fluctuations of their own cycle, but now it's amplified by uterine inflammation.
The ultimate medical trade-off. You get near-perfect efficacy without systemic hormones, but you sacrifice control over the physical reality of the menstrual bleed, which forces millions of patients to turn away from the copper device and look toward the systemic hormonal options to, regain that control.
And when we look at the hormonal options, the real-world typical use numbers jump significantly. Combined oral pills, the patch, and the vaginal ring, all of which rely on that estrogen-progestin synergy, sit at greater than 90% effective in typical use.
We are talking roughly 7 to 9 failures per 100 people.
Right.
But notice that it's not 99%. Even with powerful systemic hormones, typical use still drops the efficacy by almost 10%. Because taking a pill every day at the same time requires immense cognitive load and adherence.
It does. If you want to hit that surgical 99% efficacy with hormones, you have to move to the set it and forget its methods.
Like the progestin-only IUDs and the subdermal implants.
Yes. These methods sit at 98 to 99% efficacy in the real world because they completely bypass the patient's memory. The provider inserts them and the device handles the daily dosing automatically. Typical use becomes literally identical to perfect use.
Compare that to the injectable hormonal option, right?
Yeah.
Depo-Provera.
Yes.
Molecularly, it is a massive dose of progestin that completely suppresses ovulation. In a lab, it's near flawless, but in the real world, its efficacy drops to around 90 to 92%.
Because the patient has to physically remember to drive to a clinic, wait in a waiting room, and receive an injection every 12 weeks.
Right. If their car breaks down, or they can't get off work, they miss their window, and the pituitary wakes back up. The pharmacology is only as strong as the logistics.
Which is why the source material emphasizes that prescribing these medications requires an intense, highly personalized clinical evaluation.
You're not just picking a statistical winner off a chart.
No, not at all. You're not just assessing which mechanism is statistically best. You are assessing the patient's lifestyle, their cardiovascular history, their lipid panels, and their risk for estrogen-dependent cancers. Every single prescription is a highly curated negotiation between efficacy, systemic risk, and human behavior.
And the most common outcome of that negotiation, the absolute workhorse of this field, is the combined oral contraceptive, the birth control pill. The source spends a massive amount of time on the combined pill playbook, unpacking the specific role of the synthetic estrogen component.
Which is almost universally a compound called ethinyl estradiol.
Right, ethinyl estradiol. Why is that specific molecule so important?
Well, ethinyl estradiol is a fascinating molecule. Native estradiol, the kind produced naturally by the dominant follicle, gets rapidly destroyed by the liver if you try to take it orally.
It just gets chewed up.
Completely metabolized before it can do anything. But by adding an ethanol group to the molecule, pharmacologists created a synthetic version that survives that first-pass liver metabolism, allowing it to reach the systemic circulation.
But surviving the liver comes with consequences. The source points out a major historical shift in how we dose this synthetic estrogen. Decades ago, the early iterations of the pill contained massive doses, 50 micrograms or even higher. But today, the standard low-dose pill is defined as having 25 micrograms or less. Why the drastic reduction?
Because of the vascular fallout.
Vascular fallout.
Studies like the Women's Health Initiative served as a massive wake-up call to the medical community. The high doses of systemic ethinyl estradiol were directly linked to a significantly elevated risk of thromboembolic events.
Meaning deep vein thrombosis and pulmonary embolisms?
Yes, as well as strokes and myocardial infarctions.
But how does an artificial pregnancy hormone cause a blood clot in the leg? That seems so disconnected.
It all comes back to the liver. As the ethinyl estradiol passes through the liver, it doesn't just survive, it alters the liver's protein synthesis.
Oh.
Specifically, it forces the liver to drastically ramp up the production of clotting factors, like fibrinogen and prothrombin, while simultaneously decreasing the levels of anticoagulant proteins.
So it pushes the entire cardiovascular system into a prothrombotic state. The blood simply wants to clot more easily.
Precisely.
So the medical community recognized this, panicked, and slashed the doses in half to mitigate that clotting risk.
Yeah.
But here's the critical physiological question. If you cut the dose of the hormone stabilizing the system by 50%, don't you sacrifice the contraceptive efficacy?
Amazingly, no.
Really?
The lower doses are equally effective at suppressing the LH surge and preventing pregnancy. The primary casualty of lowering the estrogen dose wasn't efficacy, it was cycle control.
Cycle control.
The literature shows that patients placed on these ultra-low dose formulations experience massive rates of early discontinuation. They stop taking the pill.
And why do they stop?
The primary reason they stop is breakthrough bleeding. Unpredictable, constant spotting or bleeding throughout the month.
This is where we have to visualize how estrogen acts on the uterus. Think of the ethinyl estradiol as a thermostat governing the pipes of a house.
I like that analogy.
The estrogen keeps the internal temperature high enough that the endometrial lining stays solid and stable. If you turn that estrogen thermostat down too low, like we do with these modern ultra-low-dose pills, the pipes freeze and burst. The lining becomes unstable, friable, and it begins to irregularly shed.
That is an excellent way to visualize it. And this bleeding pattern gives clinicians a very specific diagnostic clue.
Right, the timing matters.
Exactly. If a patient experiences this breakthrough bleeding, specifically in the early to mid, say, between days 1 and 14 of their pill pack, it is a physiological signal that the ethinyl estradiol dose is simply insufficient to maintain the endometrial integrity.
The thermostat is set too low for that specific patient's biology.
Right.
So the clinician's immediate reaction should be to just bump the dose back up.
Right.
Give them a 30 or 35 microgram pill to stabilize the lining. But wait, if you bump the estrogen up, aren't you just walking the patient right back into the danger zone of blood clots and liver synthesis that we just tried to escape?
Exactly. You are walking a tightrope. Turning up the thermostat fixes the bleeding, but it amplifies every single estrogenic side effect.
And it isn't just the invisible risk of clots, is it?
No, the patient will immediately begin experiencing the physical weight of that excess estrogen. Intense nausea, severe breast tenderness, migraines, and significant fluid retention.
So how does a doctor navigate that? I mean, do you let them bleed or do you make them nauseous?
The clinical protocol requires patience. When initiating a low-dose combined pill, if the patient experiences breakthrough bleeding in the first 3 to 6 months, the standard guidance is to do nothing.
Just wait.
Wait, the body's natural endogenous hormone production is still fighting the synthetic suppression. You have to allow the receptors time to downregulate and adjust to the new, lower baseline.
You essentially tell the patient to ride it out for half a year.
Yes. It requires massive patient counseling. But if the bleeding persists past that 6-month mark and it remains locked in that early to mid-cycle window, the clinician has no choice.
They have to turn up the thermostat.
They must step up the estrogen dose to regain control of the endometrium, monitoring the patient very closely for the emergence of severe side effects.
Are there any exceptions? like starting high immediately.
The only other scenario where a clinician will intentionally start with a higher estrogen dose right out of the gate is if the patient is taking concurrent medications, like certain anticonvulsants that induce liver enzymes and aggressively chew up the synthetic hormones, reducing their efficacy.
But let's zoom in on those estrogenic side effects, because this is where the source material gets intensely serious. We mentioned nausea and breast tenderness, which are miserable but generally benign, but the sources highlight a specific constellation of symptoms using the acronym ACHES, A-C-H-E-S.
Yes, apes.
And these aren't just nuisance side effects. These are the klaxons indicating that the biological hack has gone catastrophically wrong.
These are the absolute red flags. The AC acronym is designed to immediately identify vascular occlusion, the realization of that prothrombotic state we discussed earlier.
Okay, let's break it down. The A stands for severe abdominal pain.
Right. And this isn't normal menstrual cramping. This could indicate a clot in the mesenteric vessels supplying the intestines, or even a hepatic adenoma.
Terrifying. The C is for chest pain.
Which is the hallmark of a pulmonary embolism, a clot that has traveled into the lungs, or a myocardial infarction.
The H is for headache, but we have to differentiate this, right? Because headaches are so common. And the E is for eye problems, blurred vision, loss of vision, flashing lights.
And finally, the S is for swelling or severe localized leg pain.
So what do the E and the S usually indicate?
The eye problems and the severe headaches are classic indicators of a cerebrovascular event, a stroke.
A stroke. Wow.
And the swelling and leg pain are the textbook presentation of a deep vein thrombosis, a DVT, where a clot has formed in the deep veins of the calf or thigh.
So if a patient presents with any of these?
If a patient on combined hormonal contraception presents with any of these, the medication must be discontinued immediately and emergency medical evaluation is required.
Here's where it gets really interesting, but also a bit scary. Let's focus on the H headaches, because this is incredibly difficult to parse in the real world. Millions of people get headaches every single day from stress, dehydration, or tension. So how does a patient or a clinician sitting across from them differentiate an annoying but benign estrogen headache from a headache that is a precursor to a massive stroke?
That is one of the highest stakes differential diagnoses in outpatient medicine. There is massive clinical overlap between normal menstrual migraines and thrombotic headaches.
So how do you tell them apart?
The clinician has to play detective. Is this headache new? Has the character of the headache completely changed from what the patient normally experiences?
Like, is it suddenly much worse?
Exactly. Is it a thunderclap headache that reached maximum intensity in seconds? Is it accompanied by focal neurological deficits like numbness on one side of the face? Or the E in our acronym, visual auras or blind spots?
If the headache has an aura, if they start seeing jagged lines or losing peripheral vision, that's a hard stop, right?
Absolute hard stop. Estrogen-containing contraceptives are completely contraindicated in patients who have migraines with aura.
Because of the stroke risk.
Yes, their baseline risk of ischemic stroke is already elevated, and the ethinyl estradiol acts as a multiplier on that risk.
But what if it's not super clear?
If the clinical picture is murky and the headaches are severe and persistent but don't clearly present as a stroke, providers will often pause the contraceptive and refer the patient directly to a neurologist to rule out central nervous system pathology.
You literally have to bring in a brain specialist just to safely manage a birth control prescription. That really contextualizes the gravity of these medications.
That absolutely does.
Now, if a patient simply cannot tolerate the estrogen, whether it's due to migraine risks, blood clot history, or just debilitating nausea, the clinician abandons the estrogen entirely and pivots to the other half of the pharmacological equation, the progestins.
And stepping into the world of progestins requires a completely different clinical mindset.
How so?
With estrogen, the primary lever we pull is the dose. We turn the thermostat up or down. But with progestins, the dose within a given pill formulation is usually fixed.
Oh, so you can't just lower the milligrams of progestin to fix a side effect.
Correct. If a patient is experiencing intolerable side effects from the progestin, we don't lower the milligrams. We have to change the actual molecular shape of the drug. We swap out the specific synthetic chemical for a different one.
I think of these different synthetic progestins as a ring of slightly different skeleton keys. The biological goal, the lock we are trying to turn, is the progesterone receptor in the pituitary.
That's a great visualization.
We want to turn that lock to shut down the GnRH pulses and stop ovulation. All of the synthetic progestins are cut well enough to turn that main lock. But human cellular receptors are incredibly complex. And these synthetic keys aren't perfect.
They are far from perfect. The older generation of synthetic progestins drugs like levonorgestrel and norethindrone were structurally derived from 19-nortestosterone.
Wait, testosterone.
Yes, they literally share a molecular backbone with male sex hormones.
So, using the key analogy, these older progestins are clunky skeleton keys. They successfully turn the progesterone lock to stop pregnancy, but because their shape is so similar to testosterone as they flow through the bloodstream, they accidentally jam themselves into androgen receptors, the testosterone locks, and turn them on by mistake.
That is precisely what happens. And when those androgen receptors are activated, the patient experiences androgenic side effects.
What does that look like clinically?
The skin's sebaceous glands go into overdrive, causing severe acne. Hair follicles alter their growth patterns, leading to hirsutism, or unwanted facial and body hair growth.
That sounds miserable.
It can also cause adverse changes to lipid profiles and significant mood dysregulation. The drug is effectively preventing pregnancy, but it is deeply compromising the patient's quality of life.
So the pharmaceutical industry realized they needed a better key. They needed to laser cut a molecule that only fit the progesterone lock and ignored the androgen lock entirely. And that brings us to the newer generations of progestins.
Right. The newer molecules, like norgestimate, desogestrel, and particularly drospirenone, were molecularly engineered to minimize or completely eliminate that androgen receptor binding.
I've heard a lot about drospirenone.
Drospirenone is a standout because its chemical structure isn't derived from testosterone at all. It's an analog of spironolactone, which is a potassium-sparing diuretic.
Wait, really? It's related to a diuretic, like
Yeah.
blood pressure medication.
Yes. Because of that specific molecular lineage, drospirenone is not just anti-androgenic, meaning it brilliantly clears up acne, but it also has anti-mineralocorticoid properties.
So it prevents water retention.
It actively prevents the massive water and sodium retention that older progestins cause. This unique pharmacological profile is exactly why drospirenone is specifically FDA approved to treat premenstrual dysphoric disorder, or PMDD. It mitigates the severe bloating and the intense mood swings associated with hormonal shifts.
It sounds like the ultimate flawless key. It stops pregnancy, clears your skin, reduces bloating, and stabilizes your mood. Why on earth are we still prescribing the older, clunky, acne-causing keys like levonorgestrel?
Because in pharmacology, every alteration introduces a new variable. If we connect this to the bigger picture, while drospirenone brilliantly solves the androgenic issues, massive post-marketing surveillance data revealed a catch.
There's always a catch. What is it?
Drospirenone carries a statistically significant, slightly higher relative risk of causing deep vein thrombosis and pulmonary embolism compared to the older progestins like levonorgestrel.
Wow. So by fixing the androgen lock, they somehow accidentally triggered the coagulation cascade again.
The exact mechanism is still debated, but the clinical reality remains. If a patient comes in with severe hormonal acne, drospirenone seems like the obvious choice.
Right.
But if that same patient has a family history of clotting disorders or smokes or is obese, the clinician cannot take the risk of that elevated VTE profile.
So they have to compromise.
Exactly. They might choose a middle ground progestin like norgestimate, which has very low androgenic activity, but a safer, established clotting profile compared to drospirenone.
The curation is just endless. And let's not forget the bleeding troubleshooting we talked about earlier. We established that early cycle bleeding means we need more estrogen. How do we know if the progestin isn't working right?
It manifests at the opposite end of the calendar. The progestin is what sustains the endometrial lining in the second half of the cycle.
Right, after ovulation, hypothetically.
Exactly. So if the specific synthetic progestin isn't potent enough for that patient, or the dose is relatively too low, the lining will begin to break down prematurely.
What was the clinical signal for that?
Breakthrough bleeding occurring late in the cycle days 15 through 21. If a patient presents with late cycle spotting, the clinician knows the estrogen is fine, but they need to prescribe a pill with a biologically more potent progestin.
Wow, okay. We have dissected the exact hormonal weights and measures. We know how to tweak the estrogen thermostat, and we know how to swap out the progestin keys. But none of this brilliant molecular engineering matters if the human brain forgets to swallow the chemical.
That is the ultimate hurdle, yes.
How did pharmacologists engineer the actual packaging to manipulate human habit? As in, the source dives into Section 6, formulations, and it's wild how much psychology goes into the physical pill pack.
The packaging is arguably as important as the pharmacology itself.
I believe it.
The classic original design is the monophasic formulation. Mono, meaning one phase. Every single active pill in the pack contains the exact same steady-state dose of estrogen and progestin.
And the patient takes 21 days of active hormone, followed by 7 days of completely inactive placebo pills.
Which creates a sudden drop in hormones, triggering a withdrawal bleed that mimics a 28-day menstrual cycle.
But my question is, why mimic it at all? If the ovulation machinery is completely shut down, there is no biological necessity to bleed every month.
You're absolutely right, there isn't. The 217 regimen was largely designed in the 1960s to make the pill feel more natural and acceptable to patients and the medical establishment of the time.
So it's a societal engineering choice, not a biological requirement.
Entirely. And as modern medicine recognized this, we saw the evolution of extended cycle and continuous cycle formulations.
Oh, right. Extended cycles provide 84 consecutive days of active hormones, followed by just 1 week of placebos. You only bleed 4 times a year.
And continuous cycles ditch the placebos entirely. You take an active pill every single day, indefinitely suppressing the bleed.
Which seems like it would be a huge relief for a lot of people.
It is a profound medical tool. For patients who suffer from severe endometriosis, crippling dysmenorrhea, or heavy menstrual bleeding that causes anemia, the continuous cycle isn't just about convenience. It is a life-altering medical intervention.
You are entirely removing the physical trauma of the menstrual shed.
Exactly.
But then the source introduces something that seems to, well, move backward in logic.
Ah,
The multiphasics.
yes.
The original audio called them a pack of candy because the pills are 3 or 4 different colors. Instead of a steady dose, the hormone levels wildly fluctuate week by week. What is the logic behind intentionally destabilizing the dose?
The logic lies in highly advanced troubleshooting. Let's say you have a patient on a steady monophasic pill, but their bleeding profile is an absolute mess.
With spotting all over the place.
Yeah, right. They are spotting early in the cycle, then they are fine, then they start bleeding again late in the cycle before the placebos even start. A single thermostat adjustment won't fix it.
Because if you raise the estrogen to fix the early bleeding, you might trigger nausea. If you raise the progestin to fix the late bleeding, you might trigger acne.
Exactly. So a multiphasic pill allows the clinician to micro-target the cycle. The first week of pills might be low estrogen, low progestin. The second week, a different colored pill will drastically spike the estrogen right when the early cycle spotting usually happens, stabilizing the lining.
That is so specific.
And then the third week drops the estrogen back down to avoid nausea, but massively spikes the progestin to hold the lining together until the placebo week. It mimics the natural physiological arc, providing high doses only exactly when needed, minimizing the total cumulative hormone exposure over the month.
It's a pharmacological symphony.
Yeah.
But as brilliant as that is, the source highlights a massive failure in how these drugs are branded and dispensed. The name game.
Yes, the name game.
This is the reality of AB interchangeability and the bizarre world of generic branding.
It is a massive point of friction in clinical practice. When a pharmaceutical company loses its patent on a specific combined oral contraceptive, generic manufacturers flood the market.
Makes sense.
But for some inexplicable reason, the industry convention is to brand these generic combinations with female first names. A patient isn't prescribed ethinyl estradiol 20 milligram and drospirenone 3 milligram. They are prescribed Nikki, or Lorena, or Jolessa, or Apree.
It sounds like a roll call at a sorority house, not a serious medical inventory.
It does. But the absurdity of the names masks a very real clinical danger. The FDA considers these generics AB interchangeable.
Meaning, if the doctor writes a prescription for Nikki, the pharmacist can legally swap it out and hand the patient Lorena because the active hormonal ingredients are technically identical.
But the inactive ingredients, the excipients, the binders, the dyes, the structural matrix of the pill can be completely different.
Oh, I see where this is going.
And those seemingly benign inactive ingredients can subtly alter the dissolution rate of the pill in the gut, which alters the absorption curve into the bloodstream.
So a patient might be perfectly stable, perfectly side effect free on Nikki for 2 years. Their pharmacy switches suppliers, hands them Lorena. The patient assumes it's the exact same drug.
But suddenly, because the absorption curve shifted slightly, they are experiencing crushing breast tenderness or massive cystic acne flare-ups.
And because they don't understand the nuance of bioequivalence and inactive binders, they don't blame the generic swap.
They assume the hormones have toxified their system, or the drug simply stopped working, and they abandon the contraception entirely, exposing themselves to unintended pregnancy. It is a massive failure of patient communication.
Which brings us back to those placebo pills. If we are trying to minimize exposure and confusion, Why keep the placebos at all? If the placebo week is technically medically unnecessary for the contraception to work, why force a patient to remember to swallow a blank, inactive sugar pill for 7 days? Why not just say, take nothing for a week?
It comes down to the neurology of habit formation.
Really, just the habit.
Swallowing a pill every morning at 8 a.m. is a hardwired physical routine. If you instruct a patient to abruptly cease a hardwired routine for exactly 7 days, the cognitive friction required to spontaneously remember to restart that routine on exactly day 8 is monumentally high.
The brain dumps the habit.
Completely. Taking the placebo pill maintains the muscle memory. It maintains the visual cue of the blister pack.
That makes total sense.
And beyond pure habit, manufacturers often utilize those placebos therapeutically. They aren't always sugar. Many formulations use those 7 days to deliver continuous iron or folate supplementation, directly counteracting the microscopic anemia caused by the withdrawal bleed.
That's clever.
Some formulations even embed a microdose of estrogen, just 10 micrograms into the placebo. It's not enough to stop the bleeding, but it prevents the massive sheer drop in systemic estrogen that triggers debilitating menstrual migraines in susceptible patients.
So even the blank pills are highly calculated interventions.
Very much so.
But initiating this entire sequence, getting that habit locked in, is surprisingly fraught. The source outlines 3 completely different protocols for simply starting the very first pack of pills.
And the choice heavily dictates the immediate risk of pregnancy. Protocol 1 is the day 1 of menses start.
Okay, day 1.
The patient holds on to the prescription and waits until the absolute first day of their next natural period to swallow pill number 1.
And the biological logic here is flawless, right?
Yeah.
Because you are initiating the synthetic suppression on the exact same day the natural follicular phase is trying to begin, you crush the FSH rise immediately.
Meaning no follicles ever start developing, you are instantly protected from pregnancy, no backup condoms required.
But the logistical downside is severe. If a patient visits the clinic on day 5 of their cycle, they have to wait over 3 weeks to start their medication.
Exactly. That is a massive window where they might lose the physical paper prescription, fail to pick it up from the pharmacy, or simply lose the motivation to start.
Which is why the first Sunday start was historically popular. You start the pill on the first Sunday after your period begins.
Right.
But the only real benefit there is societal. It manipulates the 28-day math so that the withdrawal bleed usually happens during the week, sparing the patient's weekends. But biologically, because you waited several days into the cycle, a dominant follicle might have already started developing.
Exactly. The endogenous FSH might have already given a follicle a head start, so the synthetic hormones might not be fast enough to stop ovulation that month.
So what's the workaround?
Therefore, the patient must use a backup barrier method, like condoms, for the first 7 days of the pill pack to ensure the synthetic hormones reach steady-state suppression.
And then there's the third option, the quick start method, which the clinical experts in the source heavily advocate for.
The quick start abandons the natural cycle entirely. The patient swallows the first pill the exact moment they walk out of the pharmacy with the pack in their hand, regardless of whether it is day 4, day 14, or day 25 of their cycle.
But wait, if they take it on day 20, aren't they just throwing synthetic hormones into a system that might have already ovulated? It sounds like physiological chaos.
It causes temporary cycle confusion, yes. Their next bleeding profile will likely be highly irregular. And yes, they absolutely must use a backup barrier method for 7 days.
So why do doctors prefer it?
Clinicians advocate for the quick start because it solves the behavioral failure point. It guarantees the medication is physically in the patient's system immediately. It locks in the adherence the moment their motivation is highest.
Because adherence is the single most fragile link in this entire chain. Which brings us to the most panic-inducing scenario for any patient, the missed dose.
The missed dose, yes.
Life happens. Routines break. But the instructions for a missed birth control pill are wildly counterintuitive compared to almost any other medication.
That's so.
If I have high blood pressure and I completely forget my beta blocker on Sunday, and I remember on Monday morning, my cardiologist would lose their mind if I took 2 beta blockers at once. I would cause a hypotensive crisis. But for combined oral contraceptives, taking 2 pills at once is the explicit medical directive. Why does this system break the cardinal rule of dosing?
It comes down to the half-life of the synthetic hormones and the sheer speed of the pituitary gland.
The speed.
The goal of the daily pill is to maintain a specific serum concentration of progestin and estrogen in the blood, a concentration just high enough to keep the pituitary gland suppressed and block the LH surge. These synthetic hormones have relatively short half-lives. They are cleared from the blood quickly.
So if you are 24 hours late taking a pill.
The serum concentration drops below the suppression threshold. The pituitary gland, which has been artificially suffocated, instantly senses the lack of hormones.
And it wakes up.
It wakes up immediately and begins preparing to fire off an LH surge. The biological reality TV show resumes filming instantly.
The follicles start racing again.
Yes. So if a patient misses one pill, the clinical protocol demands they take the missed pill the absolute second they remember, and then take their regularly scheduled pill at the normal time, even if that means swallowing 2 pills simultaneously.
Wow.
You have to aggressively force the serum concentration back above the threshold to slam the brakes back on the pituitary before it can trigger ovulation.
But taking 2 pills at once, isn't that a massive spike of estrogen? Won't that cause intense side effects?
It will likely cause a sudden wave of severe nausea, but the alternative is an unintended pregnancy.
What if they miss more than one day?
Now, if the patient misses 2 or more consecutive pills, say they leave their pack at home and go out of town for the weekend, the protocol changes entirely because the biological landscape has changed.
At that point, taking 3 or 4 pills at once isn't going to save the cycle.
No. If you miss 48 to 72 hours, the serum levels have flatlined. The pituitary has fully rebooted, and ovulation is likely imminent or has already occurred. Taking multiple pills won't retroactively stop an egg that has already ruptured from the follicle.
So what do?
The patient must resume taking 1 pill a day to try to regain control of their bleeding, but they are entirely unprotected. They must use a backup barrier method for at least 7 continuous days.
And if they had unprotected intercourse during that missed window?
They almost certainly need to seek out emergency contraception like Plan B, which is a massive, immediate, ultra-high dose of progestin designed to violently disrupt the LH surge at the last possible second.
The physiological stakes of a single forgotten pill are just astronomical. Every single dose is doing heavy lifting against millions of years of evolutionary drive.
It is a profound daily responsibility placed squarely on the shoulders of the patient. They are manually operating a delicate, highly artificial biological stasis.
Which really brings this entire journey into focus. We started by mapping the raw, natural symphony of the HPG axis, the pulsatile GnRH, the follicular death matches, the massive estradiol spikes, and the luteal progesterone breaks.
Right, and then we saw the sheer audacity of medical science stepping in to hijack that system.
We examined how the synthetic ethanol, estradiol, and engineered progestins work in tandem to freeze the body in a simulated post-ovulatory state. We navigated the massive discrepancies between perfect laboratory use and real-world human error.
We explored the highly toxic localized mechanics of the copper IUD.
We unpacked the intense clinical tightrope of the combined pill playbook, balancing the estrogen thermostat to stop breakthrough bleeding while constantly monitoring for the AC saccharin, the terrifying reality of venous thromboembolisms and ischemic strokes.
We explored the molecular master keys of progestins, discovering how slight structural changes can either trigger severe acne or act as a diuretic to treat PMDD.
And we finally decoded the psychological engineering behind the packaging, the logic of multiphasic hormonal arcs to treat complex bleeding, the dangerous confusion of generic A-B interchangeable branding, and the strict, unforgiving physiological math behind the quick start and the missed dose. It is an overwhelming matrix of personalized, highly curated medical intervention.
It is. It's curation at its most extreme. But as we close out this deep dive, there was a single sentence early in the source material that completely recontextualizes everything we just discussed.
Oh, right.
The sources briefly mention the recent FDA approval of Opal.
Opal is a monumental paradigm shift. It is a progestin-only formulation that has become the very first over-the-counter hormonal contraceptive in the United States.
Meaning no clinical evaluation, no doctor's appointment, no blood pressure check.
You just walk into a pharmacy, grab it off the shelf next to the aspirin, and check out.
Exactly. And the tension there is profound. We have spent this entire deep dive detailing the excruciatingly complex medical curation required to safely administer these drugs. We talked about evaluating cardiovascular risk, tweaking estrogen to the microgram to manage friable endometrium, swapping specific progestin molecules to handle androgenic receptor binding, and monitoring the differential diagnosis of severe thrombotic headaches.
The clinician is essentially acting as a highly trained biological detective.
But as hormonal contraception moves out of the specialized clinic and directly into the retail aisles, we are witnessing a massive structural collision.
On one hand, this offers unprecedented vital access stripping away the financial and logistical barriers that prevent millions from controlling their own reproductive timelines. It is a massive victory for public health access.
But on the other hand, we are entirely bypassing the clinical curation. How does a patient without a medical degree navigate late-cycle breakthrough bleeding? How do they differentiate an androgenic mood swing from clinical depression?
Right. How do we replace the highly personalized side effect troubleshooting that we just established is the single most important factor in keeping a patient adherent to the medication.
It's the ultimate collision between universal access and specialized medical curation.
The science of the pill is moving out of the doctor's hands and directly into the consumer's hands. It is a massive societal shift and definitely something to deeply ponder the next time you find yourself walking past those pharmacy shelves. Thank you so much for joining us on this deep dive. Stay curious, keep interrogating the science hidden in your daily routines, and never forget that sometimes that tiny little pill in the plastic dial is actually a masterclass in hijacking human physiology.